been doing ECTs, of course, at Baptist hospitals for the longest time, but we moved all our outpatients over here since October, very quickly. It was supposed to be December, but it happened like September or October while I was away. And then I came here with 17 patients on the very first day. So it must have been a shock for you as well as it was for me when I came in. But no, the ECT is electroconvulsive therapy. The therapeutic modality is not electricity, it's actually the seizure. Electricity is just the most efficient way of inducing a seizure. So historically, the way it was discovered was by happenstance. It was actually an erroneous observation by Dr. von Meduna, next person. In Hungary, there was actually an asylum right beside the epilepsy center. And so he mistakenly identified that the people in the epilepsy center, meaning the people with seizure disorders, actually had less psychopathology than the people actually compared to the general population is what his thinking was. And so maybe he thinks that seizures might be protective or therapeutic. And so he started inducing seizures on the people at the asylum, is what they started doing. They used medications first. They used pentyltetrazole or metrazole and camphor. Probably not very pleasant. It's also very erratic just in terms of the pharmacokinetics and stuff, and so it's probably a little harder to control the seizures. Camphor, of course, is the active ingredient in mothballs, and so imagine getting that IM or IV. But that was actually very efficient in inducing a seizure. And so they did that for a few years, and then the Italians in Rome thought about maybe using electricity to actually induce a seizure instead of medications, because it's cleaner, it's easier to control, and it's easier to manage. They did the animal studies first, and then legend has it is that they have a psychotic person, a homeless psychotic person outside, and they invited them in and tried to see if he could be willing to go through the treatment. And they did, and lo and behold, the person actually got better. So that was in 1937, essentially. So the treatment has been around for almost 88 years. And the reason why we still do them to this day is because of the fact that we have not found anything better in terms of efficacy. The efficacy rates for ECT is anywhere from like 60 to 80% on treatment-resistant patients. We're not even talking about just run-of-the-mill depression. And so that's part of the reason why we're still doing that to this day. So that's Yugoslav Lusubini in 1937. Next slide. Why does it work? What does the seizure do actually to the patients? And why is it more effective than any of the medications that we have out there? The medications, particularly for depression, there's a big NIMH study that involves several thousand patients and multiple centers. And with that, they actually had like a strategic process in terms of using 4 different steps in terms of medication management. And even after patients going through like 4 different medications in either alone or in combination, their efficacy rate, the highest efficacy rate that they can actually glean from that study was only about 70%. And some question that's probably even lower than that. So you have that 30% of the population that will not respond to any of the medications that you have that are out there. And so these are the people that usually winds up with getting the treatment. So it's a very big number. Only about 2/3 of your patients may or may not respond to your medications. And this is where we come in. And so, next slide. Well, no, let's stay on that. So why does it work better than others? And we'll talk about the indications later on. The prevailing theory nowadays is the neurotrophic theory, which means that it's actually something that helps the brain in terms of restoring its function, as opposed to the Church of Scientology's mass media assault on psychiatry telling you that it causes brain damage. It's the other way around. It actually increases the substance in the brain called the brain-derived neurotrophic factors. And the brain-derived neurotrophic factors are responsible for maintaining the integrity of the limbic system, particularly the hippocampus and the amygdala, which actually shrinks over time for patients with mood disorders. And so with ECT, actually, these areas in the brain actually restores. This BDNF is supposed to restore it to its previous size. That's what it's supposed to do. So instead of destroying brain cells, it actually regenerates it for you. That's the prevailing theory nowadays. Of course, the monoamine theory tells you that it actually increases serotonin and norepinephrine and dopamine in your system as well. probably a lot more than the medications. The mechanism of action of medications in terms of the antidepressants, of course, it's a reuptake inhibitor, meaning it blocks the reuptake of serotonin and norepinephrine in your system. There are presynaptic cells and postsynaptic cells. The presynaptic cells releases serotonin and norepinephrine in your system, the postsynaptic cells takes it back. And so it works in the postsynaptic cells in terms of blocking the reuptake, and so there's more of it available in your system. The issue though is that even though after a single dose of those medications, you increase serotonin and norepinephrine, patients do not necessarily get better. There's some intervening step that happens between 4 to 6 weeks after you start the medications that's responsible for the clinical effect. And the theory, of course, is that it's probably because of the fact that that's when BDNF goes up, going back to the previous point. The connectivity theory tells you that the left dorsolateral prefrontal cortex of the brain on depressed patients tends to be hypoactive. Its metabolism is slowed down. And so it increases, of course, seizures with increased activity globally throughout your brain. But that's actually the mechanism of action for TMS, or transcranial magnetic stimulation. And so what we do with TMS is that we put a magnet on that area of the brain, stimulate that like half an hour a day, 5 days a week, for 6 weeks, and some patients might get better. The problem with TMS is that it's not as effective as they claim it is. It's probably as effective as medications. And then the indication is very narrow. It's just major depression without psychotic features, and they can't be suicidal either, because it's not been shown to help with that. And so it's very limiting. It's also very cost prohibitive if you don't have insurance. It's about $10,000 for the session. And it takes a lot of time because you have to be in the clinic every day for 6 weeks, essentially 5 days a week. And not everyone can do that. And towards the end of it, you may or may not respond to the treatment is the problem. And so insurance companies are very, very selective in terms of allocating or authorizing the treatments. You have to meet all the criteria, and the indication is just unipolar depression. It can't be bipolar depression because it's not been shown to work for that. So it's also regulates your HPA axis in terms of neuroendocrine system. For patients with depression, the cortisol levels goes up. Okay, cortisol is the stress hormone, and after patients receive ECT, actually it comes down. Your cortisol levels comes down, so that's part of that. And it's also an anticonvulsant. It's an erroneous belief that ECT will cause more seizures. It's the other way around. We actually use it to stop status epilepticus sometimes. It raises your seizure threshold. It's part of the reason why we have to keep going up on the energy as they progressively receive more treatments sometimes. Next slide. So these are the major indications. Major depressive disorder would be the primary indication. The more severe the depression is, the better the treatment actually works. It's also better for geriatric patients and probably for younger patients as well in terms of its efficacy. We can use it for unipolar or bipolar depression, of course. Bipolar depression means that you've had at least one episode of mania or hypomania, and so you can use it for that. But you can also use it for when they're manic. We haven't done that over here, but we've done that for some patients at the hospital. Schizoaffective disorders of wastebasket diagnosis. These are people with mood disorders with persistent psychotic symptoms, and it can be helpful for schizophrenia as well, particularly if you fail all the other medications. There are studies looking at schizophrenic patients with and clozaril on top of that, and their success rate is as much as 60% of those types of patients. Part of the reason why it's also very helpful for schizophrenia is the fact that ECT actually prevents suicide. That's something that nobody talks about. Schizophrenic patients, 10% of them will kill themselves routinely, regardless of what they do. But thankfully, there are some medications that may mitigate that. Clozapine is the only one that's been proven for schizophrenia, and the thing for bipolar patients. None of your antidepressants have actually been shown to prevent suicides or decrease suicidality, which is an interesting thing. Next slide. Other indications would be catatonia. We see a lot more of these. Catatonia, of course, is a neurological condition where the patients, there's 3 varieties. You have the retarded catatonia, which is what most people associate that with. They get really stiff, they stop speaking, they stop moving, they can maintain awkward positions for long periods of time without getting tired, essentially. But there's also an excited catatonia where they have repetitive, purposive types of movements You can see this sometimes in autism spectrum disorder patients when they just start smacking themselves repeatedly, kind of stuff. So that might be a variant of catatonia as well. There's a third variety called malignant catatonia where you actually have autonomic instability on top of all those things. And so you can see this in patients people with anti-NMDA encephalitis. And we've treated patients who are intubated, they're on pressors because their blood pressure went down and then they go into respiratory failure. And we can get them out of that kind of state within a few days after they start treatment. The key is diagnosing it very quickly because it's fatal if you don't diagnose it within 5 days for the most part. So we see some of these patients at the hospital. You can use it to actually treat neuroleptic malignant syndrome, people who actually have problems with antipsychotic medications and just reacting to that violently. And some would argue that NMS is actually a variant of catatonia. And as I said, we have some epilepsy or seizure disorder patients that actually come in for both the depression and raising their seizure threshold at the same time. We did one of them this morning, and they just come in once every 1 or 2 weeks sometimes, and that's enough to actually prevent them from having more seizures. We are going to treat someone with Parkinson's disease. Actually, we treated one this morning. So it both helps the depression, which happens in Parkinson's patients 50% of the time. Because of the fact that it increases dopamine in your system as well, so that the motor movements can get better after they receive treatments as well. It's not a cure, of course, because Parkinson's is a degenerative process. And you can stimulate the HPA axis as well at the same time, as part of the reason why it works on modulating cortisol levels. So, next slide, please. So the primary indication is the need for urgent response. If they stop eating, they stop drinking, they're acutely suicidal, they're psychotic, they can't take care of themselves, and this would be the quickest way to do that, to treat them. Any of your medications, they're not going to work within 2 to 4 weeks most of the time. And if they're a danger to themselves and others, then you have to do something very quickly. And of course, ECT is a very safe procedure. The movies, of course, portrayed it without the benefit of having anesthesia, essentially, because it's more dramatic that way. The treatment was set back by, of course, the Oscar-winning movie One Flew Over the Cuckoo's Nest. And that set us back years, essentially, just because of the fact that the movie was so realistic, I guess, even though it's not, it's for that period of time. It was made in the 1970s. It's of course not true, because anesthesia has been around for a while. Succinylcholine has been around since 1949. That's the most relaxant. So, of course, they didn't use that on the movie because it's not going to be. It's going to be a boring procedure if you actually just show them how it's really done. So, of course, if they have a better response to ECT previously, they will always respond to the treatment. So the good thing about the treatment is that if you respond previously to ECT, you will always respond to ECT. It's just a matter of getting how many treatments in. And of course, there's some patient preference. Patients who don't want to suffer through going through several medications, they'll just say, go treat me. Believe it or not, a lot of doctors actually fall in that kind of category. It's like, let's not mess around with medications, go get me treated. That's what they would do. Secondary indications would be if they failed medications. Usually you have to fail a few medications. But unlike TMS, you don't have to fail a certain amount of medications to get authorized to get the treatment. Severity is always the indication. If you're bad enough, then and as I said, you need a more urgent response to the treatment, then the insurance companies will okay the treatments. It's actually much harder to get the patients to get authorized to do TMS and ECT, just because of the fact that insurance companies know that ECT actually helps. It works. It prevents hospitalizations, and so it's part of the reason they do that. And again, if their condition deteriorated to the point that you need a rapid response. Next slide. Is there an contraindication to get the treatment done? The academic answer is no. Everything is relative, though, right? If they need to be treated, then they need to be treated. But of course, we have to worry about these conditions just in terms of the fact that ECT is a big stress test, essentially. There's you play around with their autonomic system. There's 4 phases of the autonomic system. Once you push the button, there's a parasympathetic response mediated by the vagus nerve, so they can go bradycardia on you. And then after that, of course, once they start having a seizure, sympathetic takes over, heart rate, blood pressure shoots up. Once the seizure is over, everything comes down again through the parasympathetic system, and there's a slight sympathetic surge as they're waking up. So we manage those 4 phases. The parasympathetic response, if they go bradycardia, we use anticholinergic medications like glycopyrrolate and atropine. Glyco is probably better because it doesn't cross the blood-brain barrier. And the sympathetic response, we usually use beta blockers. We use labetalol, esmolol. Sometimes we use hydralazine for those kinds of to control the heart rate and the blood pressure. And you can see that also as they're waking up from the treatment. And so that's how they get the beta blockers essentially towards the end. So if they had a recent stroke, either embolic or a bleed, of course, anything that's causing a mass effect on the brain, recent MI, usually we want them at least about 6 months post-MI if we can, just because of the fact that, as I said, it's a big stress test for them. Their heart rate would go up and their blood pressure would go up. CHF, and I'm not sure about the vertebral fracture nowadays just because we can paralyze the patients. Okay, next slide. So just in terms of how the procedure goes, if you haven't been in the room yet, we put the IV line in, and you guys put all the monitors and stuff. We push the medication to put them to sleep. Brevitol is a drug of choice because it doesn't affect seizure threshold. You can use propofol also for patients with very low seizure thresholds, just because that's an anticonvulsant and actually prevents you from having seizures. And so we try not to use that. But of course, younger patients have to have lower seizure thresholds, so we reserve propofol on those types of patients where their seizures tend to run very long. Once they are asleep, we give them the muscle relaxant succinylcholine is a drug of choice. You can use non-depolarizing agents as well. But we put a blood pressure cuff on the ankle before the succinylcholine goes in. Succinylcholine goes in. So we inflate that above systolic blood pressure. You should just have to put it up at 200. So the succinylcholine wouldn't travel to that foot. So that is the only thing that will be moving that while they're having a grand mal seizure. So we're just looking for 20 seconds on the motor, 25 seconds on the EEG. What is considered a long seizure is over 3 minutes. And so if they're approaching 2 or 3 minutes, we stop the seizure by giving them benzodiazepines or half the dose of the anesthetic. So the entire procedure will be done in like a couple of minutes essentially. They will clench their jaw once we deliver the stimulus though, because of the fact that the electrodes are going to stimulate directly on the masseter and temporalis muscles. So we put a bite block in there so they don't bite themselves. They're not going to be aware of that, of course, because of the fact they're asleep when this thing happens. And so the actual procedure is about 2 minutes or less for most patients. And then it takes them another half an hour, of course, to recover from that in terms of waking up. So there's some electrode placements, and you don't need to know this, but the bitemporal is the standard of care. That's the most effective version of the treatment. If they're having a lot of cognitive side effects, and anyone who's had a seizure would have short-term memory loss in and around the time that they have the seizure. Okay, so that's something that you have to explain to patients. The good thing is that it doesn't affect long-term memory. And a lot of our long-term memory is faulty anyway. What we remember is probably not true. That's just been proven time and time again by all the memory experts and experiments that we do. We tend to change our long-term memory every time we retrieve it. And you can swear up and down that that's true, but a lot of the times it's probably not right. And then there's a 9/11 experiment, there's an Emory experiment about those that actually proves that point. So right unilateral tends to be less associated with cognitive side effects on the index course, meaning an index course is when they start out. So they're getting about 2 or 3 treatments a week for a couple of weeks, usually between 6 to 12 treatments. Then after that we do what we call continuation or maintenance phases. There are some patients that this is the only thing that they respond to, but yet you have to, based on their clinical presentation, you have to just keep treating them every so often. There is no maximum amount of treatments. There are patients who had hundreds of treatments in their lifetime just because this is the only thing that works for them. It's the only thing that prevents them from killing themselves. It's the only thing that prevents them from going back to the hospital. And we have some catatonic patients that if you don't treat them within a certain amount of time, they go back to being catatonic. And so we have those kinds of patients. Those are the people that are just coming in for maintenance treatments. And so you can have as many treatments as you need. That's not a problem, unless you have any of the other relative contraindications. The right unilateral, the bifrontal, and left anterior right temporal are attempts to try to get away from the left side of the brain. The dominant hemisphere for most everyone is the left side of the brain. That's where your language center is. That's where a lot of the memory stuff is probably stored, or that's where it starts anyway. Even if you're left-handed, your dominant hemisphere usually is still the left side of the brain 90% of the time. So we try to see if we can get away from the temporal lobe, the left temporal lobe, by doing right unilaterals or bifrontal or left anterior, right temporal. So that's the reason for doing those types of treatments. Of course, if it's severe, then we do bitemporal. It doesn't matter, we're not so concerned. The thing about the memory side effects, though, is that it's something that is pertinent only during the index course, meaning you're doing that 2 days or 3 days a week. The APA actually, back in 1990, did a task force study on this, and they look at patients who have right unilateral ECTs, bilateral ECTs, and in patients who didn't get ECTs, followed them over a year. And what they found out is that at the index course, there might be some slight differences between right unilateral and bilateral, but 6 months, 9 months, 12 months down the road, everyone looks the same. So none of the memory changes actually are persistent. It's something that will eventually resolve after the treatment course is over. So I don't even worry about that. You're more worried about their mood disorders or whatever condition you're treating them, because that's probably more dangerous for them. The mortality and morbidity rates for ECT is always coded as between 1 in 50 to 100,000. So it's like getting your wisdom tooth removed, getting a colonoscopy that are probably even safer than that. And some people would even call it safer than childbirth. I don't know how we got that number. Next slide. So as I said before, we're just looking for 20 to 25 seconds on the motor. That's the foot going. And the age is about 25 seconds. Of course, even though those numbers are not met, if the patients are getting better, then we're doing our jobs. There are some patients who have that, may not, particularly the older folks. It's the older you get, the higher seizure threshold becomes. It's a lot harder for us to get seizures on. And the reason behind that is because as we age, the brain kind of shrinks over time. So the distance between the brain and the skull widens. And so you're going to require more energy to actually get to the surface of the brain. So even then, most of the energy is dissipated through the scalp, and the skull, very little actually touches the brain. It's just enough to irritate it for you to induce a seizure. Next slide. So these are the things that you see after the patients get treated. They can have some disorientation coming off the seizure and the anesthesia, of course. There might be some confusion in between treatments, particularly if they're getting it every other day. And we've talked about the memory impairment. Fortunately, it's just the short-term memory that gets affected for the most part, and you just have to reassure patients that. We tell patients nowadays to write stuff down. I always believe in the confusion saying that the slightest trace of ink is better than the best memory in the world. Okay. So of course, nowadays you can just put it on your phone. Don't lose your phone. We always tell patients also nowadays not to post anything on social media or go to Amazon, because you may not remember what you bought, kind of stuff, or what you posted. So that's something that we have to tell people now. So sometimes you would have some cardiovascular complications. As I said, it's a massive stress test for some of these patients. Headaches are very common, and it's multifactorial. Of course, you have the direct stimulation on the masseter temporalis muscle that can cause that. We increase serotonin, so patients with migraine headaches might actually have some issues with that. But there are ways, of course, to treat those kinds of things. They can have muscle soreness, particularly after the first treatment, because of the succinylcholine. Succinylcholine is a depolarizing agent. It makes all your muscles contract. And then once you stop contracting, then that's when we treat you, because that's when they're paralyzed, essentially. So they might have some soreness because of that at the beginning. But usually after the first couple of treatments, they're used to the drug. It's not much of a problem. You just give them Tylenol, give them NSAIDs if need be, if they have problems with headaches and muscle soreness. And of course, you have to worry about their tongue and their teeth. That's part of the reason why we put the bite block in there. Sometimes some patients, even with the bite block, that can still happen, so you have to warn them about that. I had one guy with one tooth at the bottom that actually managed to get through the bite block and managed to puncture his tongue, even with that one tooth. But it happens, and so you have to be very careful about that. Make sure that thing is seated when we do treat the patients. But you just have to warn the patients about that. Is that the last one? Yeah. So the take-home message is that the reason why we're doing it is because of the fact that it's very effective, and it's a safe procedure. And there's a lot of misconception associated with the treatment just because of the fact that not a whole lot of places are doing it. And the reason for that is not because of the science. The science is very strong. There are not any other treatment modalities in medicine that's more effective and more studied than ECT, just because of the fact that it's been around for a long, long time. The problem we have is availability. It has become a treatment for the, not for the underprivileged, but for the privileged few, just because of the fact that it's major medical university centers who offer the treatment. You're not gonna, there are certain states in the United States we can't even get ECTs. They have to travel across state lines to get patients treated. Part of the reason for that is because there's not enough of us doing it. As part of the reason also that we are training all of our residents to be certified to do ECTs by the time they graduate. There's only 1 out of 10 psychiatrists doing ECTs in the United States. And so we're trying to increase the numbers. And there's a lot of people, unfortunately, who are not receiving the treatments when they need to, just because there's not enough of us doing it. And so we're trying to change those numbers, we're trying to train all of our residents to do that. By virtue of that, as I said, it's not available everywhere. There's a lot of places that don't even have it, and they have to be transferring patients left and right. North Carolina is blessed, because you have three universities that does this, and then you have places like Charlotte and some other places that can do it. But in other states, there's like no one. In Vegas, there was no one when I went over there. In Idaho, there's no one. I have a resident going to Idaho, tell him that you should start a service over there. Dr. G actually came from Idaho, I think, and he was the only game in town for the longest time when he was there. And just imagine. We still have patients traveling 2 to 3 hours to get here, just get their treatments done, just because it's not available everywhere. But the big stigma, of course, is that because of the movies and stuff, you have to explain everything. There are some videos that you can look at. The ISEN is called the International Society of ECT and Neurostimulation. One of those videos actually had Dr. G in there, so you should check that out. And so that's something that you can use for your education and actually for patients as well.
Can you send me that link through email, and I can share that with the team?
And so they have it's like an infomercial essentially from all over the world essentially. So we have one from Wake Forest, we have one from Dartmouth, I think. There's one from the University of Michigan. There's one from Australia. But there's some videos in there about how the treatment is done. But it's and unfortunately, the problem we have now is the fact that you are seeing some of these patients, particularly the ones that we're getting index scores, in their acute phases. Some of them are not sick enough to be in the hospital, but not well enough either to function in society. And those are the ones that you might be encountering. We might have some catatonic patients coming in when they're starting out. We might have some psychotic patients coming in. We try to do them in the hospital if we can, but some of them, they may start at the hospital, but then get discharged from the hospital and then will continue the treatments here, even though they're still psychotic or catatonic or still not well. And so those are the things that you may have to encounter while we're doing this as an outpatient. When we were doing it at Wake Forest, of course, there was no distinction. Inpatient and outpatients were done at the same place. So it's all different here just because of the fact that you will just be seeing outpatients, and not all of our outpatients are well. Most of our outpatients, though, that are receiving maintenance treatments, they are well now. But when they started out, some of them, you won't believe that they're the same person. And there's some of them that you can see there's still behavioral flags in there, just because of the fact when they were not well, they were a handful. They should take those behavioral flags now that they're well, but they don't. But that's in a nutshell what you'll be seeing out there. And if your safety is an issue, always call security. Never wait for anything. And we can always have enough. A show of force is always better than trying to talk anyone out, particularly some of our patients. The problem with psychiatric patients is the fact that they have what we call prosopagnosia. They don't even know they're sick or they're not well. They don't have the insight that there's something wrong with them sometimes. And that's going to be a problem. So there's no talking around that. And delusions are fixed false beliefs. You don't reason out for those kinds of things. You just treat them. And so if safety is an issue, make sure you call security. You need to give them IMs, we give them IMs, and we've done that before. But we always tell our residents and everyone, don't be a hero. If you feel unsafe, just leave. call security. Fortunately, most of the patients get here, there's a very big screening process before they even get here. You see them at the neuromodulation clinic, gather all their information, make sure everything is in check in terms of their labs, transportation, and that kind of stuff. Some things may still fall through the cracks, but before they get here, they've been re-evaluated and re-evaluated before we even say yay or nay, and before we start treatments. And so we'll try to screen them as much as possible, but of course, when we have some sick patients that require treatment and you don't know how their conditions are up until they get here sometimes. So that's the challenge. But as I said, we'll try to treat them as an inpatient if we can, but the problem we have with inpatients is the fact that the average length of stay is about 3 to 5 days. They are not going to get better very quickly in 3 to 5 days. None of our treatments work that very quickly. So you will see some of them as they're transitioning out of the inpatient still. Okay. Questions?
A couple.
Yeah.
First of all, thank you very much. It was very informative. It's a lot more than I knew about the process. But why do you think that there's a limited number of physicians? Is it more equipment availability, or is it more misconceptions
No, it's
of
not.
physicians?
It's just that the training programs, not everyone does it. So there's a lot of centers that don't even have physicians that are trained.
Right. So training just that intense?
Yeah,
and
it's not really that intense actually. There are like week-long visiting fellowships in certain centers, but that usually is not enough. It's not incorporated in a lot of residency programs is the problem. I was lucky that I was actually trained at SUNY Stony Brook. When I was there, Max Fink was there. Well, Max Fink is the founding editor of the Journal of ECT. So my claim to fame is that I am the last fellow that he trained. And so I made him retire after he finished. Now he was 70. He's 102 years old and still answering emails.
Wow.
So he's the first, he's probably responsible for keeping the treatment alive when everyone turned their backs on it. And so there's a website that's managed by the Church of Scientology called Hall of Shame. Max Fink was #1 for a long, long time. He's #2 now, I think. Aaron Saka from Columbia took over. But now he was, when psychiatrists turned their backs after the movie came out and they stopped doing it. Back in the day also we had a lot of what we call psychoanalysts. Of course we've gone away from that, thankfully. But no, that's what happened. And so people turned their backs on ECTs, and then they thought that the medications, since there's advent of the medications, they thought that the medications will fix everything. And of course we found out that that's not true. There's actually a podcast by the Seattle Public Radio called Lost Patients. And these are chronicling patients that are actually out in the community just because of the fact that we decided to shut down a lot of our state psychiatric hospitals where these patients belong. So instead of being in the state psychiatric hospital, they're out there in the streets. There's an episode called The Churn. And so the churn meaning that they just go in circles. They would come into the ED, they wind up in a psych unit or a rehab if they have some drug problem, and then they get spewed out to the streets because most of them would be homeless, they don't have any social supports. Or worst case scenario, they wind up in prison because they committed a crime. And then they go back to the ED again. And so it's like a revolving door. And we keep discharging them to like shelters and stuff where they're not gonna be able to take their medications. There's no social supports whatsoever. They belong in state psychiatric hospitals just because not all of them are well. Schizophrenia is the cancer in psychiatry. We don't have an answer for schizophrenia yet, or chronic psychotic illnesses. And nowadays, of course, this is all complicated by the fact that there's a lot of drugs and alcohol that are out there. Addiction is a massive, massive problem in the United States. And so it's before we would not admit anyone with a positive drug screen. Now everyone's positive drug screen. Of course, pot is legal. Like THC, the amount of THC that's in today's pot is about marijuana is about 5 times the amount of THC available back in the 60s and the 70s. And it's part of the reason that you can get really psychotic with just smoking marijuana nowadays. And of course, we can see catatonia. We've been seeing some marijuana catatonia as well.
So we legalize it.
Yeah, but it's the same thing with the, of course, alcohol is legal, so of course prohibition does not work either. But the whole idea though is we need to have places for these types of patients. We just stop caring for the seriously mentally ill. Society, as a society in general, we just turn our backs on them, and that's an uphill battle for the psychiatrists. It's very frustrating. I cover the emergency room once a week on Thursdays, and it's the same kind of thing. And people, the residents, some know some of these patients by first name. Just he's bad. It's because they go through the churn. The biggest psychiatric provider in the United States are prisons, and that's where they're winding up. And they don't necessarily belong there, but they don't have anywhere else to go. Is what happens. And some patients will actually deliberately commit crimes just so that they're not in the elements and they're not homeless, they're not living in tents or living in wherever they can find a space. And so it's a shame as a society that we've done this. And this all started in the 60s, not even a new phenomenon, but to this day, nobody's taking a look at that. They're looking at the homelessness problem as something, I think we're not even addressing that, we're just ignoring it altogether. So long as they're not in our neighborhood, then it's fine. But it's not, right? As a society, we have to care for all these patients, essentially. So that's where the frustration is. And as I said, this treatment is something that's not readily available. There's some state hospitals who don't even offer ECTs. So, and those are the patients that are probably benefit from the treatment most. It's because they usually have the severely mentally ill, persistently and severely mentally ill. Did that answer you?
Yes,
Yeah.
thank you. How quickly do you usually see some sort of relief from these patients? Is it after 2 or 3 treatments? Or
We always say 6 to 12,
6 to 12?
but a lot of the times within the first week or so they'll notice a difference. Usually the relatives who notice it first before the patients. Of course, if they're not eating, they're not drinking, then if they're catatonic, they start moving, they start talking, you'll know right away. The problem with catatonia nowadays is that they're requiring more and more treatments just because the complexity of the patients have probably gotten higher. So that's something that we need to look at. Why is that happening? Why are patients being more treatment resistant? It might be true, the same is true with the antibiotics. We just keep using a lot of the medications, and some of the medications unfortunately just raises their threshold more. So what happens? Ketamine is one of the other problems. There are ketamine infusion clinics out there with no scientific basis behind them that are taking advantage of desperation of our patients. And they're charging them an arm and a leg because insurance does not cover it. They pay out of pocket. We had one patient who was getting IM ketamine out somewhere in the clinic. It's like, IM ketamine doesn't even get absorbed very well. And they were giving him like Mickey Mouse doses and paying $500 every time they come into the hospital. And of course, ketamine, you get addicted to ketamine. So they thought they're getting better, they're actually they're probably just dissociating so that they don't care as much. Of course, the effect goes away. And the problem with patients that have ketamine is the fact that once they get ketamine, it's a lot harder to treat them, even with ECTs. It takes them a longer period of time to recover. And of course, you can have dissociative episodes with ketamine, and it's not the safest drug either from a cardiovascular standpoint. Like heart rate, blood pressure goes up on ketamine, and they get sick to confused. They can get psychotic on ketamine, and they really have to be watching. The only thing that's FDA approved is ketamine, which is the inhalation of ketamine. But you have to watch them in the clinic for 2 hours after you give them a dose, just because a lot of stuff can happen within those 2 hours.
I have one more question, and then I'll leave you alone. If a patient has a negative reaction in one of the 4 phases, are they more likely to have another one?
What do you mean?
Like if their blood pressure severely drops, or if they have heart side effects, or?
No, it's up to us to decide. Patients don't even remember what happened. Usually, it's how it goes.
But are they more likely to have that happen again in one of those phases, or is that
the
kind
good
of a
thing is that we
one-time?
always work with the anesthesiologist to prevent those things from happening. And so if you know they're at risk for that kind of stuff, for instance, if they have a very robust parasympathetic response, they go bradycardia, we give them glyco right up front. I don't usually give that out all the time. I use that for the first treatment, just because we don't know what their seizure threshold is like. The worst case scenario is that you press the button and they don't have a seizure, so you have the unopposed parasympathetic response. They go bradycardia. Worst case scenario, they just go this way. and sometimes it happens. So by giving the glyco, that prevents that from happening for you. The problem with glyco is that it's an anticholinergic agent that lasts in your system for a while. It's an awful drug. Anesthesia likes it because it prevents secretions from happening, so they don't have to use the suction. But rather than use the suction, and the patient's dealing with dry mouth, blurry vision, and constipation for a week after getting a single dose. And so it's not a very pleasant drug that way. If you know that their blood pressure shoots up, we pre-medicate them with beta blockers or hydralazine. That's usually what we would do to make sure that we prevent that from happening. And so there's a lot of things that you can do after the first treatment. You'll figure out how the patients respond. Essentially, you always ask them whenever they come in if there are any kind of changes in their medical condition. Of course, if they're on blood pressure medications, we allow them to take that first thing in the morning, like 6 in the morning, with a small sip of water, and that usually prevents a lot of those things from happening as well.
Those are great questions, Christina.
So my hope is that you spread the gospel. You just let people know that this is a safe procedure and it works, despite of all the negative publicity around. Unfortunately, as human beings, we're more attuned to negative stuff. It's a self-preservation kind of thing. Anything that's positive will be met with a lot of distrust, particularly nowadays, unfortunately. So, and there's a lot of hysteria that's going on, particularly with this treatment. It's probably a prototype for that kind of stuff in terms of fake news. So, ECT is probably the progeny for fake news in terms of how that goes. It's poorly understood even by people in the medical field, which is even neurologists. We have to educate our neurologists just in terms of what to expect or what not to expect. One would think that they would know that because we take the same boards. We're the American Board of Psychiatry and Neurology. And sometimes you have to educate the neurologists. We've had patients with anti-encephalitis at the hospital with catatonia, and they would refer them to us like 3 months after their hospitalization, which is totally absurd. And of course, we would still treat them, but it would have been nice if you referred them like on the first few days that they were here. So we're not very good at diagnosing the condition. And the condition has been described, catatonia has been described in the 1700s. And the pathophysiology we think with catatonia is that there's actually a decrease in GABA receptor activity that leads to dopamine depletion or decrease in dopamine activity. So what the simple test to do is what we call the lorazepam challenge. We give them a milligram of lorazepam IV and see if the catatonia actually gets better. And the thinking behind that is not because of the benzodiazepines, it's because of the fact that benzodiazepines are very good GABA receptor agonists. It increases GABA receptor activity. So if it's from catatonia, you give them Ativan, they usually will get better temporarily. If they do get better, you can put them on a standing dose of the medication. Usually they require much bigger doses. You can go anywhere from like 3 to 24 milligrams. Certainly way beyond the anxiety doses. And if that doesn't work, then you can give them ECTs. Of course, if they're not eating, they're not drinking, you need to move ECT right away. That's what we do. And it's a very common condition. As I said, it's not just from psychiatric condition. Most patients with catatonia have bipolar illness. It's a misconception that they're schizophrenics. Most of them have some kind of mood disorder. We saw a lot of post-COVID catatonia. And we still have some patients actually with long COVID that has some catatonic features. And that we're treating at this point. You can see that in mixed edema coma, people with severe hypothyroidism, and any of the autoimmune illnesses like SLE and stuff like that can also present with catatonic features. So we just have to be attuned to doing that. The biggest problem with catatonic patients because of the fact that their dopamine are depleted already in terms of their activity, some of them would get agitated, and guess what they get? They get an antipsychotic medication. And so you make the decrease in dopamine activity worse, and next thing you know, they're having full blast neuroleptic malignant syndrome. So that's a no-no for catatonic patients. And sometimes that's how we get the patients from neurologists, because of the fact that they have catatonia, they get agitated, they get an antipsychotic medication, they go into full-blown NMS. And that's when they get referred. So so we have to educate our residents and make sure that our consultants keep an eye on that. As much as 10% of ICU patients will probably have some catatonic features. So it's not an uncommon condition.
Wow.
So You just have to you need to have a high index of suspicion and be on the lookout. And it's easy to treat. You can just give them benzos and that usually resolves the problem for the most part. So most of them will actually recover spontaneously, so long as you don't give them an antipsychotic medication. And for those who don't, that's when we come in.
All right, I have one more. I'm sorry. How do you know when they're done with treatment / how do you transition them? Do you transition to medication or do you transition to therapy or both?
We do
Or
both,
how
yeah.
do you know when they're not going to benefit anymore or they're recovered enough to get off?
Yeah, we say 6 to 12. And
Okay.
so that's an adequate trial for most patients. There are some patients who require more than that though, unfortunately. And so we have to let them know after 12 treatments, we do a reevaluation, see if they want to keep going or not. If they're slightly better, then we certainly encourage them to keep going. If they're not any better, then we have to give them the decision just in terms of do you want to keep going or do you want to stop. Because there are some patients who require more treatments. Ironically, healthcare providers are the ones who require more treatments. Doctors and nurses are very hard to treat. 6 to 12 treatments for most people. Doctors and nurses, we're looking at 20 or more before we can turn them around. I don't know why that is. That's just the case. But usually what happens is that we get them better. They do PHQ-9s. That's the depression questionnaire if they're depressed. Of course, if they're manic, you know that the mania has resolved. If they're psychotic, symptoms have actually petered down or at least very minimal. And then we tell them that the option would be to either stop now and then just come back when you have a recurrence of symptoms. Usually what I do is get them to where they need to be, put 2 more treatments on top, and they will stop it. Okay. For patients with chronic illnesses that's been dealing with this for years, we usually try to do what we call a slow taper. There is no standard procedure for the taper. It's a matter of how the patients react. And so we always ask them, how are you? If you stretch it out to 2 weeks, are you still doing well? Good. We'll stretch it out to 4 weeks. Are you still doing okay at 4 weeks? Yeah, we'll stretch it out to 6 weeks. If they get to 3 months, they probably don't need the treatment. That's usually how it goes. But we do have patients that just come back once every 3 months. Ironically, she's a retired nurse. She just gets 1 treatment, and that's enough to keep her out of the hospital, with or without medications. And we have some patients without medications who just come in for treatment once a month, just because they have all sorts of problems with side effects on the medication. And they're willing to do that just because of the fact that it's cost effective from that standpoint because it prevents hospitalization. It also doesn't disrupt their lives, and so they can go back to where they need to be. We have people who are able to go back to productive lives in terms of finishing school, getting back on their jobs and stuff like that, which they were not able to do, of course, when they're not ill and they keep going back to the hospital. We have one guy who's getting maintenance treatment now. He's just coming back every 2 to 3 months. He had his first manic episode as a senior in college. He was a computer science major, so he was in the hospital for 3 months before he got referred to us. We were able to get him better. He finished school and now he's working. So, and he just comes back every 3 months. He's definitely afraid of coming back every 3 months, but he does. And family makes sure he comes back because he gets really psychotic when he's not well. So, but you can't tell when you see him. You don't know that this is what's happening. So there's actually one of the very first TED Talks is by Dr. Sherwin Nuland. He's the doctor who wrote the book How We Die, which is a good book about end of life care essentially. And so if you haven't read that, you should. It's called How We Die. But one of the very first TED Talks is titled How ECT Changed Me. You can look it up. He gives you a nice humorous history about ECT, and then he tells you his personal experience how he actually got the treatment when he was in his 40s. He became severely depressed, got divorced, and was in the hospital. And they were about to do a lobotomy when he said to one of the right residents, "Hey, why don't we try ECT first?" This was during the time when people were turning their backs on ECTs, essentially in the 70s. And I think he mentioned he got like 23 treatments before he turned around. And got out of the hospital, became the chief of surgery at Yale.
Oh, wow.
So, look it up. It's one of the very first TED Talks. It's called How ECT Changed Me. It's actually in the Eisen website also, I think at this point. And so it's something that works. It's not going to cause you brain damage. It's not for everyone. We're definitely not saying that, but certainly for people who are suffering needlessly, and a lot of the times they're not even given the option. A lot of the patients that are referred to our clinic said, "How come nobody talked to me about this?" Because of the fact that a lot of the times the service is not available, and so most of the clinics that they go to. So.
Well, I want to thank you for coming today, listening to our concerns again, even our questions at the end, the professionalism that you brought, and the olive branch that you put across the table for our last conversation. So thank you so much for everything, and